Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and this week I've got a new voice to the pod, Dr. Sanjay Mohan, EM doc and toxicologist working at Northwell LIJ, the sister hospital to where I work at Staten Island University Hospital. Sanjay and I both trained at Bellevue, though a couple years apart in time, just to give him credit for the age difference here. It's great for us to be back together. We really haven't had a chance to have these kind of conversations in a while. So Sanjay, welcome to Rebel.
Thanks, Swami. It's a pleasure to be here. Yeah, it's been a little bit, but it's a nice little reunion.
And I didn't just mention Bellevue to give a shout out to our old institution. The reason I mentioned it is because Bellevue is a center of excellence for alcohol-related pathology. We're very proud of our ability to manage everything alcohol-related. And so we've got a topic that is going to be right in your Bellevue wheelhouse: alcoholic ketoacidosis, or AKA.
Yeah, alcoholic ketoacidosis is one of those diagnoses that I think every emergency medicine clinician should be aware of. It's one of those things that I put in the same bucket as your shoulder dislocation, flash pulmonary edema. It's a diagnosis you can make quickly and really turn around within the span of a few hours in your emergency department.
Oh, and we love that in EM. Things that not only I should be able to identify pretty quickly, but that I can take care of pretty quickly as well. Let's start with a little bit of background. Give me a little bit of background on AKA.
Yeah, so AKA, or alcoholic ketoacidosis, is a starvation state that occurs in patients with severe ethanol use disorder. I actually think this is something that we frequently miss in the emergency department because it is, frankly, easy to miss. So the issue with patients with severe ethanol use disorder is that they're often malnourished. And as a result, fatty acids and proteins are broken down to generate ketone bodies, which is the source of energy.
With all of that in mind, how are these patients going to present to the emergency department? Because you said up front, this is often missed. So how are they going to present? And we really want to know, how can we pick up more of these cases instead of discharging them home?
As with everything else in emergency medicine, it's all about pretest probability, right? It's risk stratification. So typically, it's going to be in a patient with severe ethanol use disorder, and they might have some vague complaints: nausea, vomiting, abdominal discomfort. But the real takeaway, at least in my opinion, is looking at the physical exam, right? Kussmaul breathing, as always, is an indicator of badness. And just to reiterate, Kussmaul breathing is that fast, deep, and labored breathing. In contrast to other cases of respiratory compensation, there's this weird tendency for patients in AKA to actually maintain their mental status and remain lucid despite the degree of tachypnea. Moreover, tachycardia may also be present due to significant volume loss. In patients with severe ethanol use disorder, given their propensity for poor diets, they may have severe electrolyte disturbances as well. Hypokalemia, hypomagnesemia can also be found. The initial ethanol concentration may be low or undetectable. Patients with alcoholic ketoacidosis can have severe metabolic acidemia, which is interesting because despite a pH of 7 or 6.9, it doesn't correlate with how sick the patient actually looks.
So there's a couple of things in there from the physical exam side that we have to be looking for. Maybe just kind of take a step back from the patient and just watch them breathing. That might be one of the tip-offs here. That tachycardia, I think, is really important. And we see so many patients with alcohol use disorder that come in describing abdominal discomfort or nausea and vomiting. If they're not that tender on exam, I often see patients get like a little bit of some Malox, maybe a PPI or an H2 blocker, and then we watch them for a little bit and we send them on their way. But if they are not responding to those things, if they're tachycardic, we should be more concerned. And that should be a trigger then to get labs, because Sanjay, you and I know we don't get labs on these patients all the time. And so those lab values, while we need to be keyed in once we get them, it's the trigger to actually obtain labs that's really important for us. So watching that breathing, doing that good exam, looking for that tachycardia, all of those things should set us down that pathway. And then knowing what to expect, that they can have a lot of electrolyte disorders, that they can have pretty severe acidemia in spite of them not looking so sick. Those are things for us to keep in mind once we actually get those labs. What about making the diagnosis itself? So once we've decided this patient doesn't look as good as I'd like them to, they don't look like they did yesterday when I saw them with intoxication, I'm going to go ahead and get labs. What clinches the diagnosis for us?
I think the first thing I would look at is a blood gas. These patients will 100% be acidemic, whether it's 7.1, 7, or even less than 7. They'll likely have a lactate as well. And most importantly, they'll have ketones, whether that's a beta hydroxybutyrate in your serum or acetoacetate in the urine.
So those things we're going to be looking for to clinch this diagnosis. It's actually relatively straightforward once we pull the trigger and get those labs. Now that we've got those labs in front of us, so we see that acidemia, we see the ketones, let's shift to management. What are the things that we should be doing for these patients to fix them up? And then that's going to also help us to bridge to what we're going to do in terms of their disposition.
For sure. And this to me is the best part. It's actually quite simple. These patients need volume repletion, they need sugar, and they need thiamine. Ultimately, they just need to be fed. And if they can eat, that's great. More often than not, they can't eat because of how unwell they are, in which case you're going to give them sugar-containing fluids, whether that's D5NS or D5LR. Don't forget thiamine, 100 milligrams intravenously. And you also want to fix their concurrent electrolyte abnormalities, whether that's the hypokalemia or hypomagnesemia.
All right, so the big thing here is to get fluids going in, make sure those fluids have sugar in them, give them thiamine. We've talked about Wernicke's in the past. We'll drop a link to that just for people to remember what they're looking for as possible Wernicke's, knowing that the supplementation of thiamine for preventive reasons is different than the supplementation for once you think they actually have Wernicke's. So we'll put a link to that. You can go back and check that out. Give them sugar-containing fluids, give them thiamine, fix the electrolytes. Let's say that I do those things and the guy looks pretty good. Is this on your way, or should they in general be admitted to the hospital?
No, generally these patients should get admitted. Given the degree of acidemia, there's probably other electrolyte abnormalities going on. And more importantly, and I'm sure you know the Swami training at Bellevue, this is an incredibly vulnerable population, right? They need to be hooked up with other social services. They need to be hooked up with addiction counseling. And at the end of the day, probably admitting these patients is what's best for not only them, but for society as a whole.
And I think we also have to keep in our minds to look for some of the concomitant things that might be going along with this. So does this patient have alcohol withdrawal? Do they have pneumonia? Do they have pancreatitis? All of these things can come together. So we just have to be keeping an eye out for those things as well and make sure that we're not just focused in on the AKA and missing something larger that might also be going on for the patient. Sanjay, before we wrap up, how about a couple of big take-home points for people to leave with?
Totally. So alcoholic ketoacidosis can present with significant acidemia, sometimes with a pH less than 7. Despite the degree of acidemia, these patients can remain alert and lucid and look better than their severe metabolic derangement. Treatment consists of thiamine, dextrose, and volume repletion. And as always, remember to evaluate for concurrent medical illness in this vulnerable population. They may just have AKA, but they may have something else going on, pancreatitis, pyelonephritis, or sepsis.
All right, that's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks on their cast. In the meantime, don't forget to pop on over to the site and check out all the great posts from our faculty. And until next time, stay safe.